Professeur Sok?
Essayez de l'appeler au téléphone.
Oui, il y a quelqu'un qui avait désactivé mon micro, ce n'était pas moi. Hein.
Ah, d'accord. Allez-y, professeur Sok. Tout le monde est là. Hein?
Allô, vous m'entendez?
Oui, bien sûr, on vous entend. On vous entend, professeur Sok.
Bonjour, bonjour.
On vous entend très bien, professeur Sok. Vous pouvez y aller, s'il vous plaît.
J'ai l'impression qu'il n'a pas de retour. Hein?
Bonjour, professeur Ndoye.
Bonjour, professeur
On vous entend,
Sok.
professeur.
On vous entend. Il a un point de retour. Là.
Oui, apparemment, le professeur Sok a quelques difficultés techniques. Mais peut-être que dans l'attente, professeur Ndoye peut prendre le relais pour qu'on ne soit pas en décalage par rapport au temps imparti.
Merci Galaï. On va rappeler une dernière fois.
Moi, je vous entends bien, mais apparemment, là, il y a un problème, vous ne m'entendez pas.
Si, on vous entend bien. On vous entend bien.
Professeur Sok, c'est la technique. Tout le monde vous entend normalement. On ne sait pas si vous nous entendez bien. Si vous nous entendez bien, vous pouvez commencer.
Professeur Mamadou Ndoye?
Oui, on vous entend, professeur Sok. Allez-y.
Moi, je les entends, mais ils ne m'entendent pas.
Si, on vous entend. On vous entend. Un peu de retour, là. On vous entend.
On vous entend très bien, professeur.
Professeur Sok, on vous entend.
Il faut l'appeler au téléphone, lui expliquer, comme ça il peut commencer.
Mais comme je disais, il est à l'étranger, là. Il n'est pas... Il n'est pas à Dakar.
Le portable est d'animation.
Professeur Sok? Professeur Sok? Mais je pense, en attendant le retour, là, je pense que la suggestion du professeur Galaïstal est très bonne. Je vais peut-être rapidement souhaiter la bienvenue à tout le monde et puis passer la parole en attendant. Et dès qu'il rentre en ligne, il pourra prendre le relais.
Okay. Bonjour tout le monde. Vous m'entendez mieux maintenant, peut-être?
On vous entend, on vous entend. Professeur Sok, on vous entend, allez-y.
Ça me marque systématiquement, l'autre a désactivé votre micro.
Ok.
Donc, votre micro marche bien, professeur Sok, allez-y.
Bonjour.
Bonjour, bonjour. Professeur Sok, allez-y.
Bonjour.
Allô, professeur Sok? Écoutez, on va démarrer la séance. Je vais peut-être souhaiter la bienvenue à tout le monde au nom du président de l'Académie, au nom du président, du secrétaire perpétuel, le professeur Omar Sok. Je voudrais donc souhaiter la bienvenue à tous les participants, à tous les invités, à l'Académie nationale des sciences du Nigeria, à l'Académie des sciences du Ghana, à la Gambie, et nos collègues du Sénégal. Donc, souhaiter la bienvenue à tout le monde et à tous les participants.
Professeur Mamadou Ndoye?
Professeur Sok, vous pouvez y aller.
Est-ce que professeur Omar Gaye ou professeur Salif Sow m'entendent?
Oui, on vous entend.
On vous entend très bien, professeur Sok.
Oui, mais j'arrive pas à voir professeur Ndoye. Donc,
Non, allez-y,
moi, je
allez-y.
pense qu'on va démarrer. Si vous m'entendez, on peut démarrer.
Allez-y, allez-y, on vous attend. Vous pouvez faire votre introduction, s'il vous plaît.
Professeur Salisso, je vous vois, mais je ne vous entends pas.
Moi, je vous entends très bien. Est-ce que les autres m'entendent?
On vous entend
Oui,
tous.
on vous entend.
Tout le monde vous entend. C'est la technique. Tout le monde vous entend.
Très
Oui,
bien.
oui.
Donc, moi, je propose que nous démarrions parce qu'il y a apparemment quelques problèmes techniques qui
Allez-y.
peut-être ne nous empêcheront pas de démarrer la séance. Est-ce que vous m'entendez tous?
Oui.
Professeur Sok, on vous entend. Allez-y. On vous entend tous.
Très bien. Je n'ai pas de retour de Salif Sow,
Mais parlez, on vous entend.
apparemment,
Parlez, on
les
vous
autres
entend.
m'entendent.
Allez-y.
C'est ce que me dit Aïssatou qui est à côté de moi là.
On vous entend.
On vous entend. On vous entend.
Bien.
Professeur Sok, tout le monde vous entend.
Donc, au nom du professeur Doudouba, qui peut-être prendra la parole tout à l'heure s'il est connecté, le président de l'Académie nationale des sciences et techniques du Sénégal, et au nom de tous les membres de notre académie, je voudrais saluer et remercier toutes les institutions qui ont accepté de participer à ce projet et au présent atelier régional virtuel de sensibilisation et de partage des policy briefs consacrés aux interventions non pharmaceutiques sur la COVID-19 au Sénégal, en Gambie, au Ghana et au Nigeria. Je voudrais adresser nos sincères remerciements aux institutions, l'Académie des arts et des sciences du Ghana, l'Académie des sciences du Nigeria, nos partenaires dont nous saluons la participation très active à ce projet. Et bien entendu, nous tenons à remercier particulièrement l'Académie nationale des sciences des États-Unis et l'organisation Resolve to Save Lives pour leur appui déterminant dans l'élaboration, le financement et la mise en œuvre de ce projet qui nous réunit aujourd'hui. Je voudrais remercier tous les modérateurs qui vont participer à l'animation de cet atelier régional et bien entendu remercier au nom de tous les experts qui ont accepté de présenter des communications au présent atelier régional sur la COVID-19 et la sensibilisation et le partage de bonnes pratiques sur la COVID-19 avec les moyens des méthodes non pharmaceutiques. Bien entendu, vous le savez, les extraits de cette activité, c'est des policy briefs à adresser à nos décideurs pour contrer la COVID-19 par ces méthodes non pharmaceutiques, bien entendu, qui vont se coupler aux méthodes pharmaceutiques pour obtenir les meilleurs résultats possibles. Je vous remercie. Voilà les quelques mots que je souhaitais prononcer au nom de notre académie et du président de Dubaï à l'entame de cet atelier régional. Je ne sais pas si le président Doudouba nous entend, auquel cas il pourrait dire quelques mots. Sinon, nous allons passer directement au déroulé du programme proprement dit. Et je passe la parole au modérateur Pape Salif Sow et professeur Darkoua pour les premières présentations de cet atelier régional. Professeur Pape Salif Sow, vous m'entendez?
Merci beaucoup, professeur Sok. Merci beaucoup. Apparemment, la technique, nos collègues anglophones
Pape
ont
Salif
des
Sow,
problèmes.
votre
La
micro
technique.
est-il activé? Je vous vois parler, mais je ne vous entends pas du tout.
Mais les autres m'entendent, professeur Sok. Vous avez un problème de retour.
Oui, en effet, on vous entend.
Oui.
On vous entend, effectivement.
Merci beaucoup, Abdou Salam.
Sally peut y aller, hein, je pense.
Merci
entend,
beaucoup. Hein? Merci beaucoup. Merci beaucoup, chers amis. Ladies and gentlemen, welcome to this first session of our workshop this afternoon on COVID-19 response in West Africa, strengthening knowledge sharing and best practices. My name is Papa Salif Sow. I'm an infectious disease physician from the Senegalese National Academy of Sciences and Technology.
The therapist that I need to work it.
And it is my pleasure to co-moderate this session with my colleague, Professor Akosua Darkwa from the Ghanaian Academy of Science. And it's my pleasure to introduce our first speaker today, this afternoon, Dr. Ngozi Azoda from Nigeria. Dr. Ngozi, are you online? Dr. Ngozi from Nigeria, are you online? Blessing, could you please let us know if Dr. Ngozi Azoda from Nigeria is online?
On la voit dans la liste des participants. C'est la technique, on la voit dans la liste des participants.
Okay, so Dr. Ngozi is our first speaker this afternoon. And as I said, it's my pleasure to co-moderate this session with my colleague, Professor Akosua Darkwa from the Ghanaian Academy of Science. And Dr. Ngozi, she's a public health physician. She serves currently as the director, head of the Department of Health Planning, Research and Statistics of the Federal Ministry of Health in Nigeria. And Dr. Ngozi is one of the critical persons at the front line to the response and management of the health sector response to COVID-19. And she is involved in the development and implementation of the National Health Sector COVID-19 Pandemic Response Action Plan in Nigeria. So Dr. Ngozi, if you are online, the floor is for yours for 20 minutes. Thank you.
Thank
Dr.
you.
Ngozi.
Thank you very much. Can you hear me, please?
Yes, we can hear you. We can see you.
My name, like I've already been introduced. I'm very honored to be part of this very, very important discussion on taking the COVID-19 response.
Go ahead, Dr. Ngozi.
Speak about social determinants, epidemiology, and response to COVID-19 pandemic in Nigeria. And I gave an outline. I don't know if they can share my slides.
Yes, go ahead. You can share your slides, please.
Okay. There's an outline.
Nous avons quelques problèmes techniques. La technique, qu'est-ce que vous pouvez faire pour l'aider?
And it has affected very strong health systems. Nigeria has experienced epidemiological and sociological impact of this pandemic, and we are looking at it and addressing all the issues around it from a socio-economic point of view and also from a health, point of view. We have we can name many containment measures which we have taken as a country. While a lot of these are beneficial, unfortunately, they also hurt, very critical aspects of our life, like the economy, the security of our people, and, brought out the psychological water supply, we have congested environments, we have issues around culture and religion, and we try to address all these aspects of our response. So what did we do? What did Nigeria do? Well, this is an academy of science. I'm not going to be talking about COVID from a scientific point of view. We're looking at how we addressed it.
Est-ce que vous entendez le docteur Ngozi?
On n'entend pas, hein?
Non, on n'entend pas.
Oui, oui, il y a un problème technique. La technique, est-ce que vous pouvez nous aider?
Yes, I don't know who muted me, but I think maybe a call came and it went in mute. So we had a state of preparedness, an initial state of preparedness, which included setting up an interministerial task force by the Ministry of Health. We had the Ministry of Aviation, the Ministry of Humanitarian Affairs, the Ministry of Information and Culture, and of course, Port Health Services at the Nigerian Center for Disease Control. So once we had the pandemic, once a pandemic was declared in compliance with international health regulation, IHR 2005, Nigeria immediately established a whole of government approach, which we call the Presidential Task Force on COVID-19. That Presidential Task Force was chaired by the Secretary to the Government of the Federation, and it briefed the President on a weekly basis and as frequently as it was required to. The Minister of Health and his entire critical team of NCDC and the Secretariat here were part of that Presidential Task Force. The Presidential Task Force swung into action, and it had the responsibility to stop further transmission of COVID-19 within Nigeria. It had to ensure the provision of basic treatment to those who were already affected, to reduce the overall social and economic impact of the pandemic within the country. And it operated through a center we call the National COVID-19 Response Center, and it was within the presidency. So we had all of this going on. So the PTF coordinated multi-sectoral actors because like we all know, the COVID is no longer a health issue alone. We had to coordinate resources involved because of the huge amount of resources that were involved in managing this COVID, especially in addition to the treatment and management of the clinical or health component of, we also needed to look at the issues around lockdowns, the impact on employment, the impact on schools, the impact on our social everyday life. So it put a lot of pressure on government. We also needed to ensure proper synergy and efficiency among all the players and to outline a strategy for social welfare and economic recovery during and post the pandemic outbreak. And we spelled out the roles of other sectors in the pandemic response. Well, the number of non-health sector response, and this is where the social determinants again come in. We had the non-health sector responders. We had the Ministry of Humanitarian Affairs, Disaster Management, and Social Development. As you are all aware, we have so many IDP camps in Nigeria. We have the Northeast, which was the only region, majorly security challenged at the time. But of course, there were a number of IDP camps, resulting from other issues beyond security, like flooding and all of that across the country. We also had the Emergency Management Agency. We had the Federal Ministry of Information, because misinformation and management of information became a very serious aspect of managing COVID-19. We had a lot of experience from our Ebola management, and we put that into use here. We also needed to liaise and work very closely with Ministry of Education and the aviation sector, because children were going to lose a whole year in the academics. We had to devise other means of making sure that the children kept going to school virtually, just like we're having this meeting virtually. So those were some of the things that we had to do. So if you look at my slide, you would see
you are not sharing your slides. You are not sharing your slides. Doctor, you are not sharing your slides.
Well, have
can you allow me to share her slides from this end, please?
It will be great, Blessing. Go ahead.
Yes, okay, thank you. I'll share it now.
Thank you, Blessing. Please, Dr. Ngozi, you can go ahead while Blessing is preparing to share your slides. Dr. Ngozi. La technique, nous avons vraiment des problèmes techniques. Hein?
Bonjour tout le monde, c'est la technique. Vous m'entendez? Oui, je pense que Dr. Ngozi a des problèmes de connexion à son niveau.
Ah,
parce que nous, on vous entend bien et ça dégrade un tout petit peu lorsqu'elle parle.
Absolument. C'est un problème de connexion high-speed Internet.
Effectivement, merci.
Blessing? Dr. Ngozi, maybe you can go without your slides.
You should see in a few seconds.
Dr. Ngozi?
And I'm saying that we had to address the issues of social protection. We provided palliatives and distributed things. The Emergency Management Agency, food had to identify locations where people don't have non-food items, like toiletries, like baby food, like yes, we also had to address. Please go on to maybe slide number what? Go forward more and more. Okay, here, this is where I am. So in partnership with the Federal Ministry of Information, we also address the issue of infodemic, the dissemination of accurate information. We try to monitor media coverage and, working with the Ministry of Aviation and Water Resources to make sure that simple messages are passed on and that people who didn't need to be in Nigeria, we're not in Nigeria. So we looked at the issues around the pandemic. This graph shows you just a graphical picture of what the pandemic looks like from 2020, from April to March to May 2021. You can see where the epidemic curve, when it peaks, around June last year, and then around January, February this year, and it has been coming down. And so that's the pandemic, the epidemiology of the pandemic. The next slide also just shows you in figures what the pandemic looks like in Nigeria. Then we are looking now at the health sector response. Next slide. If you look at the health sector response, I already spoke about the structure that we use. What we tried to do was to have one plan, one holistic plan. Next slide, please. One holistic plan. That plan, we call it the National Health Sector COVID-19 Pandemic Response Action Plan. What the plan did was to integrate all the various plans that were being used across the country. What we did was to integrate that into one response plan so that we can promote transparency and accountability, and we didn't have any overlaps. We also try to address the issue of the pillar of maintenance of routine health services, because we realized that during the COVID, the routine health services were badly overlooked or ignored. So our data was showing, and all of that, routine immunization, in order to also, while addressing all the health services. Next slide. Next, we looked at, in order to address the plan. We also had our parastate as part of the plan. We had the Nigerian Center for Disease Control. We had the National Primary Healthcare Development Agency. We had the, next slide, please. We had the Department of Hospital Services. We had the Department of Public Health, which works through the Port Health Services, which is the point of entry. We had the National Agency for Food and Drug Administration and Control. We had the Department of Health Planning, Research and Statistics, which functioned majorly as a coordinating secretariat. We also have other agencies which had roles to play, not as critical at the peak, but every role was very important and critical. So what did NCDC do? NCDC had the responsibility, like the foremost a public health response agency that it is, to lead the preparedness, the detection and the response to infectious diseases and outbreaks, including this one, which is the public health emergency. So it intensified crisis and risk communication. We intensified infection prevention and control. Over 45,000 healthcare workers were trained eventually. We started with very few people who knew what to do in the event of pandemic. Now we also scaled up testing. We had that we are capable of. We have a network of public health labs, over 80 networks of public health labs, over 80 labs that have been strengthened and certified to not just test for COVID, but for other public health emergencies. And the NCDC has put that as is required into a public health laboratory system. And that is an ongoing and growing infrastructural development. We also have the genomics surveillance that has also started being done in Nigeria. We didn't have any of this before the COVID. So while we were addressing the issues of the COVID, we also had to look at the issues around public health security and the system that supports that. So we are building a resilient health system as part of our public health response. We also had our Institute of Medical Lab, medical research and development, and the pharmaceutical research and development, everybody working to see whether we can get local alternatives to some of the interventions that we have. The National Primary Healthcare Development Agency is focused on public health communication and also vaccine. We plan through the agency to reach 70% of our population with the COVID-19 vaccine by end of 2020. Of course, all of us here know that the supply of COVID-19 vaccine has been seriously challenged, through or because of all the issues that around India and the outbreak they're having, the third phase they're having, it's become a real problem. So we are still hopeful that I'm working through other sources, including bilaterals, to ensure that our supply is maintained and we're able to meet our targets. Right now, we've immunized just about 2 million Nigerians, with the second dose. Well, we're in the process of immunizing 2 million Nigerians with the second dose. The first dose was received by 2 million Nigerians. So we have started the second dose. The initial plan was to immunize 4 million people and get the next batch and start immunization. But on realization of the challenge that may exist with, the disruptions in supply, we decided to finish the first and second dose, the second dose for those who have done it the first time. So we have a very robust strategy towards the vaccination, which we call TEACH strategy, traditional vaccination campaign, electronic self-registration. We have assisted electric registration of eligible Nigerians. We have a concomitant vaccination along with electronic registration and house-to-house electronic registration.
Dr. Ngozi?
Yes, please.
Could you please go to your conclusion? You have already your 20.
Okay. Okay, so in conclusion, we've also had a very robust treatment approach. We've established isolation centers in all the states of the Federation. We have established labs and all of that. We have also strengthened our public port health services for port of entry. And as you can see on our website, we keep updating what we require to do for everyone to ensure that when you enter Nigeria, you are safe and the Nigerian public health is safe. We are strengthening the National Agency for Drug Administration and Control, which certifies all the vaccines, but also we are looking at local production of vaccines will require a level 3 maturity. In conclusion, the Federal Ministry of Health, Government of the Federal Republic of Nigeria, continues to maintain a robust, very robust response approach, and we have a Secretariat and Statistics. That Secretariat is providing coordination for everything we're doing, including the Ministerial Expert Advisory Committee and the Vaccine Coordinating Committee. Thank you very much for listening to me. God bless you.
Thank you, Dr. Ngozi, for sharing with us the Nigeria National Plan to respond to COVID-19. Thank you for very, very helpful, very holistic approach, and also the progress made regarding vaccination COVID-19 in Nigeria. So thank you very much. We'll be back for some question clarification at the end of the second presentation. And now it's my pleasure to ask my co-moderator, Professor Akosua Darwa from the Ghana Academy of Science, to introduce our second speaker this afternoon. Professor Akosua, you have the floor, please.
Can I be unmuted, please?
We can hear you very well. Go ahead.
Oh, okay. Good afternoon, colleagues. Our next presenter is Dr. Oladoyin Odubanjo, the Executive Secretary of the Nigerian Academy of Sciences. Over to you, Dr. Odubanjo. 20 minutes, please.
Thank you very much. Actually not the presenter. I think it's my job to present the presenter. So I'm happy to introduce today Dr. Olutobi Shanuade. I hope I pronounced that right. So Olutobi Shanuade is a research fellow at the University College London, UCL's Institute for Global Health. He has a background in sociology from the University of Ibadan in Nigeria. He's had pre-doctoral training at the Population Research Institute, Pennsylvania State University, USA, and has postgraduate qualifications, both MPhil and PhD, in population studies from the University of Ghana. He did his postdoctoral training at the UCL's Institute of Advanced Studies, where he worked on a Wellcome Trust-funded project on critical histories of chronic diseases in Africa. His research interests focus on chronic and non-communicable disease prevention, experience, care, and health systems response in low and middle income countries. So it's a pleasure this afternoon to present to us Dr. Shanuade, who will be presenting on the state of knowledge in the social sciences and humanities on COVID-19 in Ghana. Dr. Shanuade, over to you.
Thank you very much, Dr. Odubanjo. Good afternoon, everyone. Please permit me to share my screen. Okay, good afternoon once again. So I will be sharing on the state of knowledge in the social sciences and humanities on COVID-19 in Ghana. And I'm presenting on behalf of Professor Amadi Graft Akins, who is not able to make it this afternoon. So my presentation is going to, first of all, I'm going to provide a background on COVID-19 patterns and interventions in Ghana. Then I will focus to what the social scientists have done in response to the COVID-19 pandemic. And lastly, I'm going to be providing future directions, what we should be looking at for the way forward. So in Ghana, the first 2 cases of COVID-19 were reported on 12th March 2020. And at the moment, as of today, there are 93,723 confirmed cases in the country. So since the first 2 cases were reported in March 2020, there have been several measures put in place by the government to curtail the spread of this virus. And I'm going to be listing, some of them. The first measure that they put in place was to put in place a 3-week lockdown in major cities in the country, in Accra, in Kumasi, and other surrounding near cities. And this is to kind of curtail the spread of this virus. Another intervention or measures that the government put in place were the strong prevention measures. And these prevention measures focused on border closures, quarantining of international air travelers, and a ban on public gatherings, including funerals and religious worship, as well as school closures. It's important to note that in Ghana, while the early cases were imported from European and Asian countries, subsequent cases were community spread. This was established quickly. And in April 2020, a month after the first 2 cases were detected in the country, the government of Ghana secured a loan of $1 billion from the IMF. And the aim of this loan is to kind of address the economic impact of COVID-19. And it was reported when the loan was taken that this loan will support small businesses and infrastructure development, as well as including building of new hospitals in underserved districts. So that was the aim of this loan. And coupled with this, the government established the COVID-19 National Fund. And the aim of this fund is to receive contributions and donations from the public. And this is to assist in the welfare of the needy and the vulnerable during the COVID-19 period. And it was reported that by July 2020, the fund had raised about 51 million Ghana cedis, which is about $606,000 US. It's also important to know that Ghana has over the first year of the pandemic, Ghana has recorded 2 waves. The first wave occurred in the early months, which was in March, April, and May. And the second wave was between December 2020 and January 2021. And there are competing theories regarding the drivers of the second wave. And firstly, the government officials blame international travel during the Christmas season and non-adherence to COVID-19 prevention protocols. On the other hand, lay people and civil society groups blamed super spreader events associated with the December 2020 elections, such as the political rallies and the victory celebrations. For those who are not Ghanaians, December 2020 was when the election took place. So some people associated the super spread, the second wave to this event. So how have social scientists in Ghana responded to this pandemic? So I'm going to be taking us through what some of our team have done, including Professor Akosua Dakar, who is the co-chair, what we've done regarding the COVID-19 pandemic in Ghana. So generally, the social scientists have tried to bring out the underlying issues driving the COVID-19 pandemic, as well as the impact. And particularly the University of Ghana playing the lead role. I've done a lot of work. So looking at the ACE-NCD, that's the Aroa Center of Excellence for Non-Communicable Disease, to which Professor Amadi Graf-Akins is leading. So one of the things that we've done is to assess the psychosocial needs of a chronic illness support group in Ghana within the context of their broader community. This support group is a group we've been working with for like 5 years. It's a group that we put together, and it involves people living with chronic conditions. So what we did in the study that we did with them was to particularly examine community understandings of COVID-19 risk, treatment, and care. And secondly, to assess the needs of the group members and to assess the community and national resources available to support the group during the pandemic. And finally, we offered practical recommendations for community support. So what we found out that with this group, there was the community understanding was limited with respect to the global and national public health guidelines on COVID-19. And we also found that there were gaps and misunderstandings regarding transmission risk and medical outcomes of COVID. In terms of their needs, we found out that when we talked to this group, they require psychosocial and material needs. They were particularly anxious about infection risk. And this is because many of them, did not have the wherewithal to engage in preventive behavior. And they were also anxious about money, where to get money, because many of them couldn't work during this period. They were anxious about where to get their food, how to get the money to get the food. And they were also particularly worried about access to non-communicable disease treatment, because many of them were afraid to visit the hospital. Many of them couldn't even afford their medications. So these are some of the needs that these people raised in this community. So in terms of the community and national resources available for them, we found out that apart from the early distribution of food by the government, no further relief was provided to this community. The COVID-19 policy that was supposed to address the needs of the poor and vulnerable was more rhetorical than evidence-based and action-oriented. In other words, the implementation activities put in place by the government did not build on best practices, the national policies and social and health protection in the country. So this was, generally flawed, as people couldn't get the relief as they should, because the government didn't engage the necessary institutions within this community. So what we concluded from this study in terms of the practical recommendations that we preferred was that in the immediate term, the solution will be to negotiate access to the COVID-19 National Fund for these residents who fit the needy and the vulnerable criteria. And in the longer term, post-COVID-19 crisis, support for these communities has to be negotiated through existing social and health protection policies. So the second study that our team also engaged in was to explore how Ghana's creative arts community shape public understanding of the COVID-19 pandemic. So we particularly focus on comedy, music, textile designs, and morals created between March and August 2020, just to understand how all of these are made use of to shape people's understanding of the COVID and their responses to the COVID-19 pandemic. So another theme led by Professor Dakwa is the sociology department. And in Prof. Dakwa's paper, she drew on Ghana's sociocultural context and provided insight into the gaps between the preventive measures imposed by the government and the reality on the ground. She clearly showed how Ghanaians drew on sociocultural factors to survive the pandemic and the constraint imposed by the government. So the paper particularly showed that in terms of what the government is proposing and how that differs from what is really happening on the ground or how people are dealing or responding to the condition. So she provides opportunities and constraints for the effective implementation of the state measures deployed in response to the pandemic. So another group that have done something to bring out the social issues related to the COVID-19 pandemic is the Institute for Statistical, Social and Economic Research at the University of Ghana. And what they did was to explore community resilience to challenges of employment under COVID-19. And finally, the Regional Institute for Population Studies have also done some work on the vaccines, on the vaccination. And the first thing they looked at is to examine acceptability of COVID-19 vaccines among healthcare workers. And what they clearly showed, this study clearly showed that, there's low intention of healthcare workers to accept COVID-19 vaccine. And this is majorly because of concerns about safety, as well as the adverse effects, side effects of these vaccines. So the other study that RIPS has engaged or what they did was to examine the relationship and decision-making in COVID-19 vaccinations. And this study is still ongoing and explores how people make decisions to receive the COVID-19 vaccines, especially because of the various IBS or myths around the vaccine and all that. So what is the way forward? There are many implications for future directions, but I'm going to be focusing on three. First, it's important to pay critical attention to complex social reality. Looking at the government of Ghana, government has a blind spot about complex social reality. And I'm going to give an example. So for instance, the government wanted to, during the COVID, one of the measures was to cover the water bill for many homes in Ghana. But the reality on the ground is that many homes do not have access to pipe-borne water. In fact, the Ghana Statistical Survey showed that just about 22% of Ghanaians have access to pipe-borne water. So the question is that, it clearly shows the gap between what the government wanted to do and the reality on the ground. And also why it is true that the government made water available for free to tankers to distribute. These tanker drivers insisted on charging for the water because the state or the government did not provide them with free petrol to distribute the water. So what it means is that for the household that have access to pipe-borne water, they ended up paying the tanker driver for their fuel and petrol. So according to Professor Dakwa, one statement that she made in her paper, which is very important, is that pre-existing infrastructural challenges thus undermine government's own efforts. So to improve COVID-19 response, it will be important to pay critical attention to complex social reality, addressing these gaps for future interventions. And secondly, it will be important to address strategic inaction to policy. For instance, focus has been on addressing the medical needs of Ghanaians to the neglect of other competing harms of the pandemic. There are other competing harms of the pandemic, such as the mental health impact, which emerged during the lockdown. For example, the rise in domestic violence cases. The government recorded, reports showed a lot of domestic violence cases, which emerged during this period. There were also stresses of childcare while working from home. These key social issues are yet to be subjected to robust research or official support, even when they have been imminent from the beginning of the pandemic. So major supports were on the medical or epidemiological needs, which are important to the neglect of the social needs. And finally, it will be important for the government to develop interdisciplinary approach to research funding. Indeed, there's a need, this is clearly needed in social public health crisis. Because if funding is not allocated in the interdisciplinary plan, we always fall behind, as there will be a narrow view on the prevention and management of the current and future pandemics. In Ghana, major funding have focused on the epidemiological aspects of the COVID and the social issues, issues of domestic violence, other economic issues were not being focused on in terms of research. So going forward, it will be important to adopt this lens or this approach to research funding. And this is how we can make progress to addressing the current pandemic and future pandemics. Thank you.
Please stop sharing your slides.
Okay.
Professor Akosua.
Thank you very much for that, Toby. Now we open the floor for quick discussions. We've got 10 minutes according to the timetable, but right now it's 2:57. So the 20 minutes becomes 15 minutes. So we'll do the discussions in 15 minutes. Professor, so you summarize for us in 3 minutes, then we'll do our discussions in 15 minutes. How about that? So,
yeah, maybe I would like to, we can go directly to the Q&A because people are waiting. It might be better.
Okay, especially since we've lost time.
Exactly.
So in that, if people have questions, comments, can we have them? If you just show by your raising your hand, or you can type a question directly into the chat. I can actually read French if my speaking of the French is not so great, but I can read it in French. So you can have it in French or in English, or you raise your hand.
Yeah. So maybe just to start, while we are waiting for the others to ask questions, Dr. Ngozi from Nigeria, thank you very much for this holistic approach. Sharing with us the Nigeria national response against COVID-19. So far, congratulations also for progress made regarding the COVID-19 vaccination. And so far you have already vaccinated 2 million Nigerians. And my question is, what is the timeline? What is your plan to cover at least the 70% of Nigerians to receive their COVID-19 vaccination? What is the timeline and the plan? Thank you, Dr. Kozi.
Thank you very much for the question. Our initial plan was for us to vaccinate 2 million Nigerians in the first by the end of April, and then to vaccinate another 20% of Nigeria between end of May and the end of the year. Now, the problem here is that we are now having challenges with COVID, the supplies. So we are expecting our next batch of supply in July. So what we are trying to do is to reprogram, our supplies, but that has to be based on availability of vaccines. while we have assurances that there will be vaccine, the AstraZeneca will be available, and we are not able to, invest in the Moderna vaccines for now, we cannot say with certainty. So we're expecting 10 million doses of AstraZeneca vaccine by July, and that's what we are planning on. Now, and right now we are also working with the Russian government, the Chinese government, and all the bilateral. We are working with several European presidents, including the French president, to see if we can get some of their excess doses of the vaccine, not as giveaway towards the end, towards the time when the vaccines are about to expire, but at the time when we can have it programmed into our existing logistic and management system. And that is, if we can get that by June, which is really in a month's time, in a few weeks' time, or as early as end of June or July. Our own plan is July, based on the existing logistic challenges we're having now, the supply challenges we're having now. Our time is July, but we're hoping that we can, with the visit of our president to France and a lot of bilateral discussions we're having, we can get a few doses before then. And so we do not have guarantees that between now and the end of June, we are going to be able to get the kind of supplies we were anticipating. And because of that, we have programmed our vaccination to restart again. Well, the second dose vaccination is continuing until 9th of July, and then the second leg of the vaccination will start 2 weeks thereafter. And that's what we have for now. And because we do not produce vaccines, we really cannot. There's so much vaccine nationalism that it's difficult for Africa, for Nigeria to make such specific plans. And so it raises the issue of local capacity for vaccine production. We must begin to speak about vaccine production, because vaccine security is national security. For Africa, vaccine security is continental security, and we must address that.
Thank you very much, Madam.
Thank you very much.
Thank you. We have to move.
Yes, thank you very much for that. Indoy, sorry if I mispronounce your name. You are next. Go ahead.
Bonjour tout le monde.
Bonjour.
Je vous remercie et je voudrais féliciter d'abord les présentateurs, le Dr Ngozi et sa collègue, pour leur brillante communication. La question que je voulais poser, Dr Ngozi, c'est quelle a été l'approche? Ils ont atteint les 2 millions de vaccinés, c'est une très bonne chose, hein? Mais quelle a été leur approche sur le plan sociologique et communautaire pour amener les populations à accepter la vaccination? Voilà, c'est la question que je voulais poser. Quelle est la stratégie qu'ils ont utilisée pour convaincre les Nigériens d'aller se faire vacciner? S'ils ont eu des difficultés, quelles ont été les difficultés et comment ils ont procédé? Merci. Thank you.
Merci. Maybe, Professor Akosua, we can have all the questions and then ask the different speakers to respond. Just to save time, let's collect all the questions and then give the floor to the speakers to respond. Next question, la question suivante. Akosua, do you have the list of questions?
There are no other questions. So let her go ahead and then we'll take the next one.
Thank you.
Dr. Ngozi. Are you there?
Hello?
Yes.
Yes.
Oh dear. Please, can you?
You had a question about how the strategy you used to get the first 2 million Nigerians to be willing to get immunized. What strategy did you use to reduce vaccine hesitancy?
Well, this is an academy of science. We also must be very practical. was a big challenge getting.
We've lost her. We can't hear you, Dr. Ngozi.
You can't hear me?
Now we can.
Now you can, okay.
Yes.
I was saying that the first thing we did was to get the strategic level engagement, which was after the usual mobilization and all of that, also get this president and his cabinet to be immunized publicly. And so that helped a lot. We got people who were at leadership level in various communities and, religious leaders and traditional leaders to also immunize people whom the people trusted. There were a number of other people that were trusted. Then there are already existing networks of health workers, like those who we used during the guinea worm eradication. They are known in the locality. They are trusted in the communities. So we use them. Of course, we continue to address the issue of misinformation. That is still a big problem because even among healthcare workers, there's still quite a bit of hesitancy, So what we're also doing now is to address the concerns of healthcare workers. We cannot wave aside the concerns of healthcare workers. If people have expressed concern, we address them. So we're taking down the professional bodies, asking them, having them, ask their questions and having it discussed scientifically and addressed scientifically. And so that has helped us. But we're not yet there. It's not yet to huru. I can't tell you that if we had 20 million doses of vaccine now, that will be able to dispose of them within a very short period of time. But of course, the more vaccines you have, the more communities you can reach, the more people you can talk to, and all of that. And then, of course, we have also suggested using incentives, like other giving mosquito nets as part of immunization in very poor communities, things that interventions that people are already used to. And that we expect to help a lot. Thank you very much.
Thank you very much for that. Francis Ankra, you are next.
Hello, yes. Mine is just a curiosity. There's a very big Muslim community in Ghana, and I note that the girls, especially those in the basic schools, religiously wear their hijab. Yet you will never see them wearing face masks, in spite of all the media advocacy on the subject. Since this bit of the work we are doing is on the psychosociological, I was wondering whether any of the Islamic educationists participating in this could shed insight on why the children so religiously wear their hijab and yet refuse, in spite of all the investment government is making, in spite of the risk that health professionals are putting their lives to simply wear the mask as they are encouraged to do. Thank you.
Toby, would you like to take that?
Okay, let me, so I can speak to that based on the people that we talked to in Gamashi. We spoke to religious leaders and some of their congregations. So when we spoke to some of the Muslim leaders, some of the things that they told us is that once they wash their hands and the feet, they are cleansed. So every other measures in that sense doesn't really have any other thing. So I believe that may be one of the reasons or possible explanations why they are not wearing face masks or adhering to all the other mitigation measures. So that's what I can say based on what we've done. I don't know whether Prof. Dakwa wants to.
Yeah, I mean, if I use a sociological sort of explanation, right? The point is, when you are wearing the hijab, you are heeding a religious command. There's a belief factor there. That doesn't translate necessarily to the COVID. So for you to wear your mask religiously, you have to feel that you are at risk. And if your religion gives you cover, then it actually makes more sense to wear the hijab so that you are under the protection of God. And if you're under the protection of God, then you don't need the mask. So it's
very interesting.
Yes, it's the religious that's actually the thing to pay attention to, because that covers your health concern. They are not two separate things requiring two different approaches. It's one thing. If you wear the mask, you are not heeding the religious. If you wear the hijab, you are heeding the religious and the health. So it's a two for the price of one solution.
So is it a possibility to have both the hijab and the mask?
That's if you separate out, you see, when you have religious belief doesn't have to be founded on the science.
Absolutely.
Right? So you, as the Academy of the Sciences, the doctors and the public health specialists and the epidemiologists, you see these as two separate things. From a sociological perspective, actually, the health can be subsumed under the religion. So when somebody, and this is not just with COVID, when somebody has cancer, they have cancer. If you're a medical doctor, you are telling them to go to the cancer center. They are going to a prayer camp, because at the prayer camp, it will cover all their financial problems and their cancer problems. But if they go to the cancer treatment center, they will just treat the cancer and not the other ailments that they have.
Wow. Very interesting.
Yeah.
Very interesting. So how are we regarding the time, Professor Akosua?
We have 7 more minutes. I think we should take another question if we've got it, and then probably give ourselves a 2-minute stretch break.
Yes, we can have maybe 1 or 2 additional questions before closing and going to the next session. Question from the floor, participants? Yes, Mr. Alun Jai. Alun Jai, vous voulez parler? Vous êtes muté.
Again?
Alun Jai? Yes, allez-y, Monsieur Ndiaye.
The line is breaking, I can't hear you.
Hein?
Allez-y, Monsieur Ndiaye.
Bon, je voudrais remercier tout d'abord l'ensemble de tous ceux qui ont fait des présentations. Mais je voudrais aussi remercier l'Académie qui nous tient informés de l'ensemble de tout ce qui se passe dans le monde, et notamment actuellement comme la COVID est pratiquement l'élément phare. Donc, nous sommes bien au courant grâce à l'Académie. Je voudrais aussi poser la question de savoir, quand on parle d'immunisation, l'immunisation est-elle un vœu pieux ou une réalité compte tenu des études qui ont été effectuées? Ensuite, j'ai vu dans les publications qu'il y a des cas, notamment aux États-Unis, où la langue des gens peut être très augmente d'une manière telle que la personne ne peut plus manger, ne peut plus parler. Alors, je ne sais pas si il y a eu des cas aux États-Unis et notamment au Texas. Est-ce qu'en Afrique, les chercheurs, les observateurs ont vu des cas similaires?
De quoi exact?
C'est des gens qui ont été attaqués qui ont eu la COVID et qui se manifestent par une augmentation exagérée de la langue au point qu'ils ne peuvent plus parler, qu'ils ne peuvent plus manger. Et il y a eu des cas aux États-Unis, particulièrement au Texas. Alors, est-ce que ici en Afrique, on a eu des cas, même si c'est des cas, disons, pas élevés, mais s'il y a eu 1 ou 2 cas de ce genre? Merci.
Merci beaucoup, M. Ndiaye. Pour la dernière question, ça rentre dans ce qu'on appelle les fake news. Ce sont des vidéos, malheureusement, qui ont circulé et qui ont dit qu'avec le COVID, on a la langue qui est augmentée, qui est multipliée par un facteur 3,5 qui ne peut plus continuer dans la bouche. Non, scientifiquement, ça n'a pas été décrit et ce sont vraiment des fake news. La première question, l'immunisation collective, oui, c'est ce que nous visons dans tous les pays. La vaccination est la seule stratégie pour sortir de cette pandémie. La vaccination est la seule stratégie pour contrôler cette pandémie. Donc, on vise ce que nous visons dans tous les pays. C'est ce qu'on appelle une immunité collective, de vacciner minimum 70 à 80% de la population. Et il est heureux aujourd'hui que dans beaucoup de pays, on l'a atteint, notamment Israël. Vous voyez, il y a le nombre d'hospitalisations est pratiquement diminué, il n'y a plus de décès par COVID et la vie reprend. La vie reprend. Et donc, c'est ce que nous devons faire dans tous les pays pour arriver à cette couverture de vaccination collective qui nous permettra de sortir de cette pandémie. Professor Akwa, I think we are over time now. Maybe it's time to conclude and to take over to the next session, right?
Thank you very much. So now we've got 3 minutes and I don't see any other hand up. So I suggest we just take
Let's conclude.
Yes.
Go ahead.
So, do you want to conclude or should I wrap up?
Go ahead, ma'am.
Okay, so we've had a good first session on Nigeria and Ghana and the state of knowledge in both places. One gave us a science approach in terms of the approach to dealing with the crisis and the various mechanisms and processes that were put in place to make that happen. Then the Ghanaian case contrasted with that by giving us insights into the social science approaches to the pandemic. One of the things that I found really useful in the earlier presentation by our Nigerian participant was to point out that dealing with COVID requires not just the science or a health sector response, but a non-health sector response as well. So as then Toby concluded, it requires an interdisciplinary approach, and it's adopted. I also found it really interesting to pay attention to the response. So in particular, in the Nigerian case, hearing about the importance of the Ebola response in preparing them for dealing with the pandemic. But then she also makes a very good point about Africa and our lack of vaccine production and what that means for us going forward. And in terms of thinking about lessons from this pandemic is to think about how we ensure that in the years ahead, our reliance on the generosity of others is reduced, because what the pandemic has shown is that when push comes to shove, when there's a crisis, it will really be each man for himself and God for us all. And so on that note, and now that it's exactly 3:20, I guess we get no break. We go into the next session. And the next session is going to be moderated by Professor Ndoye and Dr. Doyin Odubanjo. So thank you on behalf of myself and Papa Salif. So
thank you very much.
Thank you. Professor Ndoye.
Oui, bonjour, Professeur Salif Sow.
Vous avez la parole.
Oui, je voudrais avant tout, avec l'autorisation du président, du professeur Omar Sok, je pense que président de la séance, s'il nous entend, s'il peut dire un petit mot avant de me donner la parole, si c'est possible. Professeur Sok. Professeur Sok.
Il a des problèmes techniques.
Quoi qu'il a des problèmes techniques, je pense.
Allez-y, professeur Ndoye.
Donc, nous allons aborder la deuxième séance. La deuxième séance va convoquer les présentateurs du Sénégal, de l'Académie nationale des sciences du Sénégal et de la Gambie. Le Sénégal va être représenté par deux conférenciers. Chacun va parler pendant 10 minutes, alors que la Gambie sera représentée par un seul conférencier qui parlera pendant 20 minutes. Donc, je vais commencer par le premier conférencier du Sénégal, c'est le professeur Abdou Salam Fall. Abdou Salam Fall. Donc, le professeur Abdou Salam Fall est directeur de recherche titulaire des universités en sociologie. Il est titulaire de 2 doctorats en sociologie urbaine à l'université Cheikh Anta Diop de Dakar et en sociologie économique à Amsterdam, School for Social Sciences, Amsterdam, aux Pays-Bas. Le professeur Abdou Salam Fall est le coordonnateur du laboratoire de recherche sur les transformations économiques et sociales de l'IFAN. L'IFAN, c'est l'Institut français l'Institut africain d'Afrique noire. Donc, chez Anta Diop, on l'appelle l'ARTES. Il est responsable de la formation doctorale sciences sociales appliquées au développement de l'école doctorale, études sur l'homme et la société. Le professeur Fall est également membre de l'Académie nationale des sciences et techniques du Sénégal. Alors, riche d'une expérience de plus de 30 ans, le professeur Fall, donc, dirige depuis 15 ans la formation doctorale, donc on l'a dit, et il a co-publié une douzaine de livres au sein des maisons d'édition internationales. Donc, je vous fais grâce de ces livres, en tout cas, c'est une douzaine de livres. Et donc, sans plus tarder, je vais passer la parole au professeur Fall, qui va nous parler de l'impact de Covid-19 dans la société sénégalaise. Le professeur Abdou Salam Fall est avec des collègues, Rokhaya Sissé, Soufianou Moussa, Moussa Fassé et Elhadj Malick Ndiaye. Professeur Abdou Salam Fall, vous avez la parole.
Je vous remercie infiniment.
Pour 10 minutes.
Et pour ne pas perdre du temps, après avoir vous remercié tous de cette opportunité d'échange, je voudrais passer la parole à ma jeune collègue Aminata Tolufal, qui va vous faire la présentation au nom de l'équipe, qui est ainsi affichée.
Merci beaucoup.
Good afternoon, everyone. It's a real pleasure to share with you this presentation on the impact of COVID-19 on Senegalese society. And the following slides are a summary of a couple of studies that have been led by the Research Laboratory on Economic and Social Transformations in Dakar, Senegal. Mainly the barometer on education in 2019 that concerned more than 60,000 households. The survey with l'ARTES and IFPRI on the impact of COVID-19 on women in rural areas, so about 3,003 women. The survey on the impact of COVID-19 on families in about 700 households in 4 regions of Senegal. The study on the impact of COVID-19 on cultural actors done in 2020 that concerned about 441 actors. And finally, the study on the impact of COVID-19 on small and medium enterprises that concerned about 200 small and medium enterprises. So just a brief plan on the following slides. So first, the situation before COVID-19, so the precarious living conditions of Senegalese society, and then the impact of COVID-19 on the following indicators. So first, hunger, well-being, family breakdown, the impact on cultural actors, the impact on small and medium enterprises, the impact on telecommuting, and also the use of mobility. And finally, we'll be looking at perspectives, so the outlook, assessing the response, supporting government and social sectors.
Okay.
So Senegalese people tend to live in precarious living conditions. with still strong geographic disparities. So most of the people reside in the capital, so about 31%, and then a multi-polarized human settlements, but also new regions that are sparsely populated. In terms of collective dynamics, the household size is quite large, about 10 people on average, led by household heads between ages 40 to 59, and then a quarter of those household heads are women. But the precariousness that we described earlier is quite persistent. We see about 34% of tenants are accommodated. Precarious habitat, most houses have more than 60% that have no cement on the ground, a quarter of no wall on the main building, about 2/3 of the roofs are not concrete, and 2/5 of households do not have access to electricity, and 79% do not have modern toilets. So 70% do not have a refrigerator. In terms of access to social protection and social coverage, including family grants, universal health coverage, and other forms of social protection, we see that there's a very low access to social coverage. So about 17% of households only have coverage. In terms of standard of living, it's in better proportion than the living environment that there. Okay, so the middle class is expanding. So we see that there's an enlargement of the middle class, so about estimated at 67%, an increase in nearly 10 points between 2016 and 2019 in good living standards, so about 22%. And this situation overall reveals the value of favoring the community approach in governance. And also we can see that COVID-19 really shows that human behavior has a negative impact on the ecosystem. So COVID-19 really emerged like a tsunami, bringing almost everything to a standstill, and also representing a turning point that re-examines the place of social policies, as well as education and particularly health, emergency on the economy and society in general. And in terms of health, when COVID-19 intervened, we see that a lot of infectious diseases were on the decline, while metabolic diseases were also on an exponential curve. So about 42% of death reported in 2015. In terms of arterial hypertension, we see 45% of women and 27% of men. And this really shows that food consumption patterns as well as environmental deterioration, mainly air pollution and healthy living, are highly affected. And it also shows a high exposure to comorbidities. Now going to the impact of COVID-19, we see that the hunger indicator has gone from simple to triple. So if you look at the graph that is exposed now, we see that the indicator of moderate to severe hunger in the household in percentage has really increased. So in the regions of Kaolack and Kolda, if you compare before COVID-19, we were at 7% in Kaolack and now at 23%. And in the region of Kolda, it went from 11.5% to 38%. So we see that there's a really high increase in moderate to severe hunger in households. With regard to women's emotional well-being, as always, women are always disproportionately affected by crisis. So there's a decline in emotional well-being. So the feeling of being unhappy has really increased. Still in the regions of Kaolack and Kolda, in Kaolack, it went from 11 to 13%, and in Kolda from 7.4% to 11%. So it doesn't seem like a high increase, but in terms of emotional well-being, it's quite significant. In terms of family ties, so we see that they're deteriorating due to the pandemic, and the figure shows that to the question of whether they were highly deteriorating, we see that more than 48.8% have said that yes, they were highly deteriorated. And in terms of medium deterioration, 33.3%. So only 17% have not reported an impact on family ties. So families are highly destructured. So the notable changes include a crisis that has strengthened exchange between generations, an increased presence of household members that help to carry out activities. All households that were surveyed had faced financial constraints. However, the resistance is quite strong. The crisis does not appear to have significant effects on the division of labor between men and women. And spending more time together, contrary to popular belief, did not promote better communication between couples. Overall, the pandemic has really created a shortfall for the overwhelming majority of cultural actors. So to the question of whether they have suffered any losses as a result of the COVID-19 pandemic in percentage, we see that more than 95.9% have reported yes. So that is a quite significant result that shows you the deep impact on the cultural sector. In terms of businesses, COVID-19 has really affected businesses, especially small and medium enterprises that suffered about 92.7%. And also faced with the health crisis, several companies are experiencing a decline in activity, which also translated into loss of income, as you can imagine. And the situation basically linked to the pandemic often leads to difficulties leading to a complete cessation of activity. So a lot of them have declared bankruptcy, liquidation, etc. And speaking of telecommuting, a lot of sectors that were ahead of digitization have resisted the pandemic better. So telecommuting has kept companies quite active, and the favorable niches, as you can imagine, are the fields of cosmetics, manufacture, sale of masks, chemicals, etc. But there's a more pressure on the agency in the work environment. So you can imagine that it really compromises leisure time and also amplifies the workspace in the domestic sphere. And also the productivity ladder as a whole is quite disproportionately expanding by slowing down the opening of workstations. There's also new mobility that has been noted with COVID-19.
Veuillez conclure, s'il vous plaît.
So development of forms of transport caused by COVID-19, a lot of quick delivery services that have been noted. So Chat, Rapid, etc. Proliferation of two wheels, so the Jakarta that we've been seeing around town, and horse-drawn carriages. And this really refers to more long-distance relationships and the use of simple technologies. In terms of perspectives, just trying to conclude quickly. So now we have assessed the response, support, employment, and social sectors. In terms of communication, evaluate the general public media campaign on TV and radio, assess the limits of local communication, and evaluate the limits of the acceptance of the vaccine in the elderly versus in the young population. In terms of social and professional engagement, trying to assess the involvement of religious and community leaders in the continuity of the pandemic, systematically observing family upheavals, which have more long-lasting effects, protecting the world of work and increased job creation for small and medium enterprises, as well as dedicate more funds. And finally, in terms of global public health strategies, trying to evaluate diagnostic, screening, and management strategies, trying to evaluate risk communication and community engagement campaigns, and finally, promote more structured investment for the social sectors, so mainly health, education, social protection, etc. Thank you very much for your attention.
Merci beaucoup, docteur. Merci beaucoup pour cette belle présentation. Je voudrais rappeler aussi que je partage la modération avec beaucoup de plaisir avec mon collègue, le docteur Oladoyin Odubanjo, du Nigeria, du NAS. Je demanderai au docteur Oladoyin Odubanjo de procéder à la présentation du deuxième conférencier qui vient de la Gambie. Docteur Odubanjo, you have the floor.
Thank you very much. Thank you very much. I'm Peyton from Banjo.
Dr. Ndoi? Professor Ndoi?
Dr. Odubanjo?
No.
Yes.
Dr. Odubanjo,
yes.
Here? Vous êtes là?
Yes. Yes.
Cheikh Ibrahim, oui, je suis là. En principe, je devais parler immédiatement après Abdussalam, mais...
Ah non, oui, d'accord. Il y a une méprise. Excusez, il y a une méprise. Donc, c'est la deuxième communication du Sénégal qui va passer de 10 minutes avant qu'on donne la parole au docteur Odubanjo. Donc, le professeur Cheikh Ibrahim, vous avez la parole pour pendant 10 minutes avant qu'on passe à la deuxième présentation, en fait, ou troisième, si vous voulez, qui vient de la Gambie. Donc, professeur, la parole pour 10 minutes.
Oui, je vais...
Vous permettez de vous présenter rapidement.
Je vais partager l'écran.
Permettez-moi de vous présenter rapidement au public. Le professeur Cheikh Ibrahim Magnan est enseignant-chercheur en sociologie, anthropologie et en sciences de l'environnement à l'Institut des sciences de l'environnement de l'Université Cheikh Anta Diop de Dakar et à l'Université américaine de Paris. Il a été conseiller technique et membre de plusieurs comités scientifiques et task force de l'OMS. Il a mené un grand nombre de travaux de recherche sur le VIH-Sida, les violences basées sur le genre et la santé de la reproduction. Il a également mené des travaux sur le terrain sur beaucoup d'affections et des interventions de type socio-anthropologique dans le cadre de la réponse à l'épidémie d'Ebola en Sierra Leone, au Mali, en Guinée et récemment à RDC, dans le Nord Kivu. Actuellement, le professeur Cheikh Ibrahim Magnan dirige des travaux de recherche-action pour appuyer la réponse à l'épidémie de la COVID-19 au Sénégal. Professeur Ibrahim Magnan, Cheikh Ibrahim Magnan, vous avez la parole. 10 minutes.
Merci beaucoup. Thank you very much. I will try to do my presentation.
Tu peux parler en français si tu veux, il y a une traduction.
Ça va être difficile de... Comme j'ai fait mon texte en anglais, ça va être difficile de lire en français.
La traduction est dans les deux langues, il n'y a pas de problème, vous pouvez y aller.
Okay. As I wrote my presentation in English, it's better for me to speak in English. Although my English is not very good, but I think you will understand. I'm trying to respond to some questions from the other side of the scientific production. Here, I will be talking about qualitative data, qualitative analysis, social construct, and narratives, and inside community perspective. I will call upon culture and gender. So I'm trying to respond to the question, what knowledge have been produced, what qualitative knowledge have been produced to do situation analysis of COVID-19 in Senegal. And then I will try to respond to the question, how to produce those qualitative knowledge, how they have been produced. And finally, this product knowledge in social science and humanities is for what? What kind of response can be constructed? My sources will come from published and unpublished papers and reports, and ongoing field qualitative data collection and analysis. And I will use an interdisciplinary approach combining philosophy, environmental science, anthropology, and sociology. The research action is the first findings that we can emphasize for the social the situation analysis is that qualitative research allow to see unseen associated epidemic, like unreported death, denial of association between death and unreported death, delay in access to health facilities, gender-based violence, and social and exclusion and crisis. Those are epidemic also. Epidemic is not here only defined in biological or biomedical terms, it is defined also in social terms. These qualitative research, they help to decode and to understand dynamic around stigma, distress, denial, fear, defiance, lack of confidence, silent resistance, fake news, and violent resistance too, as well. I will come later on with some example if I have time for that. Understanding changing space and time, the dynamic of the epidemic is very fluid. You have a lot of movement. And what's going on here is how the discourse, how the narrative will change accordingly to the change on the ground. And I will look at those data help to understand the spreaders, in particular social events, funeral, and to see behind those events, the dynamic, the quest of empathy, how quest empathy will help to explain these situations at risk and vulnerability. We also analyze the obstacles to community response, in particular governance issues, political and formal institutional will happen to be in clash with cultural and social dynamics. And finally, understanding local processes, how to construct social listening of social listening of processes and proximity communication, as well as swan effect. I took this picture of on my right of birds and flight of birds to show that from small proximity intervention, we work through that in order to get swan effects, where you have the whole group that fly together or that responds together. First, one of the findings is that social sciences and sociologists and anthropologists have been used as what I call firefighters or farmers. Firefighters because they come only to extinguish the fires, and but also they help to anticipate and to resolve violent resistance. The pictures here will show at the beginning of the disease, the epidemic of COVID, how the intervention was top down and very administrative and very coercitive, and from that you have resistance of young people who are throwing stones, and you have this attack on the logistic, and finally the final picture will show how anthropologists, in this case of Ngor, Gereu, Mbao, I have a lot of stories to share with you if we have time, how anthropologists come to help to cut down by doing communications. Inside the perspective for access to care and treatment, operational research. Social science will help to conduct operational research, in particular to see how people are running away from medical facilities because they don't want to die there, because they have a lot of systematic antagonism, systematic clash, and they have also structural clashes, or because the hostility of the environment, how it as something hostile. The cultural and social infrastructure. When I talk about infrastructure, this is what is behind. What are the concepts that are behind? What is this clash of concepts that makes the medical system so unfriendly in regard to the communities? And we look at also how the home delivery, the care at the house, home care, access to care in the house, how it's worked, and what are the social determinants, what are the dynamics, also family dynamic that can hold and take in charge the access to care during the family, and how in a containment we can think about using local traditional resources like volunteer handlers, like sending prayers will play an important role here. The symbolic grandmothers will also help to build the community or the family confidence that will allow to go further. This insider perspective is also can be used as an aspect of the operational research around vaccine and testing. Everybody talk about acceptance, but it's more hesitancy because there is no conceptual or ontological or philosophical obstacle for vaccination. And when you look at the cultural legacy, you will find a lot of wording and ontology that goes in the same line as the acceptance of the vaccination. So it is possible to build a social demand of vaccination that can resonate at the global and the international level, like a demand from African communities and societies that will request the right of having the same access to vaccine that all over the world. There is also that map I show in the right that shows that here the main problem of communication is what the level. You have a map of multi-level layers, and it shows that at the global level, at the population level, the community, the communication insists on the reductions of risk. That it shows that vaccine is efficient, and you have very few cases of adverse effect. But that level is not enough. We need because the person who have comorbidities, a certain age, or his family, or his children and daughters, they will be afraid that he may be personally at risk. So how to accompany that? How to follow that? How to create an intimate communication that that will give to people more confidence to the vaccine is a challenge that needs some input from anthropological. Producing a continuum in reproducing conceptual and social maps. The anthropologists will work on the discursive response, the metaphors, the proverbs, concept, philosophy of life and death, ontology, artifacts, symbols, the narrative, how we can use all this these resources to make a narrative, because the epidemic is also an epidemic of metaphors. It's an anthropologists like Diamond shows that when a society or a community is very hit by an epidemic, it's because somewhere the discourse itself did not change to meet the discourse that will protect people against the disease. So,
concluez, s'il vous plaît, vous avez 1 minute.
Yeah. Now to conclude, how to organize these, how to mobilize this concept, and how to help to build new identities. You know, this communication between older people and young people around the arts productions, it will be part of it. If we change the paradigm of capacity building will be completely changed. And here is some pictures that I will come later on if needed, to show how the training, how the capacity building session have been reconceptualized in the light of culture and historical legacy. New approach into volunteer work. These are some pictures that show how when you take this the responsibility to when you say to give the community the responsibility to resolve itself the issue, you will have a lot of resources, a lot of creativity that come from the communities. And men, women, the face of women, how to listen. You have all these pictures about listening and training the leaders, women's leaders, so they take control of the media and intervene in mass media communication as well in intimate communication. Here it shows how the cascades into capacity building and advocacy, you know, from the ground level all the way to the head of the state in Senegal, who accepted to, who was involved into the, who accepted.
Merci, Professor.
And here, this is just the conclusion. Social dissemination by connecting multi-level multi-level from the academy all the way down to the communities. Supports to continuing documentation and processes and lesson learned. Proposals, protocol, strategic documentation for action research and community engagement for the vaccination acceptance. Proposals for the strategic documentation for action research and community engagement for societal preparedness against emerging and re-emerging epidemic. And there is a need also to build an interdisciplinary framework for research and action. Thank you very much.
Merci beaucoup, professeur Nyan. Merci beaucoup. Donc, nous venons de voir deux excellentes communications. L'une qui a été faite par le professeur, par l'équipe du professeur, qui nous a parlé disons, des aspects sociaux de la COVID-19 au Sénégal, en nous montrant un peu les conditions, disons, le rôle des conditions de vie dans la dissémination de la maladie, en particulier, disons, le rôle de la faim, le rôle des disparités géographiques, le rôle de l'habitation, de l'habitat même du même. Ensuite, des conséquences que ça a pu avoir sur le bien-être des familles, sur la détérioration du tissu familial, et sur la déstructuration des familles. Tout cela donc avec des propositions assez intéressantes pour la prise en charge de la COVID dorénavant. Le professeur Cheikh Ibrahima Niane nous a fait une analyse situationnelle de l'approche communautaire de la COVID-19, donc avec les perspectives de recherche opérationnelle en direction du vaccin. Donc tout cela avec des propositions, en conclusion, des propositions intéressantes pour le futur. Donc nous avons fini la première communication, enfin les deux premières communications concernant le Sénégal. Nous allons passer la parole à notre collègue, le docteur Oladoyin Odubanjo, qui va présenter le deuxième conférencier, voire le troisième conférencier, le docteur Biteye de la Gambie. Docteur Oladoyin Odubanjo, vous avez la parole. You have the floor. Doctor Odubanjo.
Good afternoon, everybody. This is Blessing from the Nigerian Academy of Science. Dr. Odubanjo had to leave, so I would be presenting the next speaker on his behalf. The next speaker is Dr. Sheikh Omar Biteye, and he would be speaking on the state of knowledge in the social sciences and humanities on COVID-19 in Gambia. So Dr. Biteye, you have the floor, please. Over to you. Thank you.
Dr. Biteye. Dr. Biteye. Vous avez la parole. Dr. Biteye.
I get the Dr. Biteye's mic is his mic is off. Your mic.
Okay.
No.
Yes. Are you hearing me now?
Yes.
Okay. Thank you very much. Yeah. So thank you very much. So I will be presenting on behalf of the Gambia together with Dr. Abubakar Jany. The content of this discussion would be based on the following: introduction, the social factors that we have actually discovered in the Gambia, brief discussion on these social factors and the interventions that we have actually done so far, and also the conclusions. The first case of COVID-19 was diagnosed in the Gambia on the 17th of March, 2020. Now, if you look at the Gambia, because this is the map of the Gambia, we have a population of about 2 million people. Now, Gambia is actually surrounded by Senegal in all its region, except the Atlantic Ocean. So all over is actually Senegal, except the Atlantic Ocean. So this is very important because as we all know, because of globalization and also because of our borders, the risk of infection getting to every places in the world is actually very high. Now, this was the first case that we actually saw in week 12. That was around the 17th of March. Now, after the first case, we actually closed our airports, because before then we didn't actually close our airport. But eventually what happened when we closed the airport, because planes were not actually coming, but we also had people who were also coming from the borders, from Senegal and other countries, and entering the Gambia. So week 18, we had some other cases. Then eventually we started to begin to relax our airport closure. But what happened eventually was we relaxed the airport closure. Eventually what happened is like we had a surge. Now we had a surge, then this also came down. And the first wave actually stopped here. This was around December. So what happened in December was, because it was Christmas, December, everybody actually comes to the Gambia. So our relatives who are outside the Gambia, all of them actually decide to come to the Gambia. Then eventually what happened, you had another surge coming up. So this was the start of the second phase, which actually happened. And until now, we had almost about 5,000 cases and up to about 175 mortalities. Now we looked at the social factors. Now, what we did was to ask a question: what do they fear most? That is like, what was the most thing that the population of the Gambia fear about this COVID-19 pandemic? And one of the most important thing was death. 54% of the respondents mentioned that as the most important factor. Then psychological and mental disorders were also mentioned as other factors, and also unemployment, which is about 14%, and also economic hardship. Then eventually we went further to ask some other questions with regards to worry, whether people are actually worried for them to be infected or someone within their family to be exposed or infected. And definitely 62% of our respondents, 82% of our respondents were actually worried. And we also went further to ask questions with regards to the increase in number, whether we are actually worried about getting more cases. And that also, we had more people responding, saying that they were very worried that because the Gambia was having increasing numbers. Then eventually we asked a question about the healthcare system, whether this system, the healthcare system of the Gambia, would be able to contain this coronavirus. But definitely we had 70% of our population saying that they are not too confident. And some, between 25% said they were somehow confident. And just about 9% said not too confident. So we went further to also ask about the attitude of the people towards COVID-19 vaccine. Now, what happened was, in this, we asked this question, whether they trust the government to make sure COVID-19 vaccine is actually safe. But you can see that 23% of the population, only 23%, somewhat or a lot, trust the government to make sure the COVID-19 vaccine is actually safe. We also asked another question with regards to how likely they are also going to take the vaccine. But that also, so it's just about 21. It's only 21% of the population that somewhat likely or very likely that they will actually take the vaccine. So you can see that number one is trust. It seems as if people don't trust the government to make sure that the COVID-19 vaccine is actually safe. That's number one. And number two, only 21% are somewhat just likely to actually take the vaccination. So it means that there's definitely a problem of vaccine hesitancy. Now, when we got the vaccine, we actually went around the country to vaccinate the people. But you can see the total number of people who are actually vaccinated is about 26,000 people. Now, if you compare, yes, because the Gambia is just about 2 million. If you compare to Nigeria, it's about 200 million. So there is a big, it's just about 1% of our population that probably is actually vaccinated. And Nigeria is equally almost the same, 1 to 2 million. So looking at this, the people who were more vaccinated were people who were actually above 65 years. You can see 4,000, because these are the people whom we think are at high risk, and the health workers, and also community workers, and people with pre-existing conditions. So these people, it seems as if, they are forthcoming in making sure they're actually vaccinated. But you realize that those who are less than 40, less than 60 years of age, is very, very low. So between 18 to 64 years of age, those who are not part of this other population, like above 65, not being a community worker, not having a coexisting condition, and not also being a health worker. So amongst this population is definitely very, very low. So we have to do some more work on this in these two populations. Now, we also went further to ask about the effectiveness of COVID-19, like vaccine, looking at vaccine and also prayer. Which one do they think is more effective? Now, as the question that was asked to the Ghanaian, you can see, Professor Akosua, prayer was much more effective because we found about more than half the population who said that prayer was much more effective than the vaccine. So this is actually a major problem. Now, we also asked some further questions with regards to the assessment of the government in this pandemic. Yes, this was very good. At least about 60% of the respondents said that the government actually did very well or fairly well. But unfortunately, they didn't actually trust the official COVID-19 statistics. And also, they thought that there was also a lot of corruption with regards to these COVID-19 issues. But they were very satisfied also with the government communication. That means that at least a lot of work is actually being done in that situation. So what is the discussion here? I mean, few things that are very clear here: worry and fear related to COVID-19 population. And this is a major challenge because this, if it happens, stigma, people would not be going to the hospital because they have this fear and all those things. So it's a lot of social factors that would actually surround these issues and other issues which are very important. So this would also affect the response. And vaccine hesitancy also seems to be a major problem. Now, these two are very important things. And thus, in our communication, we have to consider this guidance and this information as very important. So because of this, our government actually set up what we call the risk communication and community engagement committees. Now, this committee is composed of government and also partners. We have government institutions like the Ministry of Health, Ministry of Higher Education, Basic Education, Ministry of Information, and Ministry of Local Government, and also Youth and Women Affairs. So it means that all different people were actually involved in this, and also other institutions like partners like Red Cross, Association of Health Journalists, different community radios, UN agencies, MRC, and GSM operators. So we try to put a committee that is composed of most of these individuals that would actually help to communicate to the different parties. Now, the main objective is to develop, organize, and guide information dissemination to the general public. This is very important because without information, it is actually going to be very difficult to, to solve this problem with fear and worry. Install and maintain public confidence, because confidence and trust is very important in any public health interventions. And also to provide information in a timely and appropriate manner. We try to give as much information as possible, almost on a daily basis, or at least once every 2 days, of what is actually happening. Address inaccuracies, rumors to minimize stigmatization, discrimination, fear, and panic. Because this is important, because if you look at what is happening in the social media, there's a lot of rumors, a lot of inaccuracies, and all these things needs to be taken care of. And also to mobilize and engage communities to develop positive attitude and behaviors. Now, this is also very important because this committee also had subcommittees at the different levels so that we can actually transmit the different information. And also to strengthen coordination between national and regional subcommittees, because this is also important. As I said, we all have borders within, Senegal, Gambia, Ghana, Nigeria, we have borders of different countries. So it is important to actually put things together make sure that we liaise between all these different committees in these different countries. Now, this was what we did. Interventions, different interventions, because this is the first press conference. So we have been giving updates and press briefing once almost every day at the peak of the pandemic. Also, we had community outreach programs to implement our activities, like the demonstration of hand washing. You can see here, going to the community to demonstrate how hand washing is actually done with just soap and water. And also house-to-house sensitization. You can see the youths going into the community with their microphones, with their gadgets, with their leaflets and everything to actually, infiltrate into the community, to talk to the community. We also got people who are their community, they are actually found in the community. We call them the Kanyalengs. The Kanyalengs, these are a group of people who are either men or women, but they are very, very well respected within the communities. And they actually try to produce songs, music and drumming and other things with regards to specific themes that we are actually interested in. If you are interested in COVID-19, they can put up, educational songs and music and stuff to go into the community, to communicate with the people in the community. Traditional communicators ready to community for community sensitization. You can see here, all of them with their microphone, to go into the community. So this was a training program that was actually done to all these communicators so that they can actually go into the different communities and reach out to the different communities and transmit the information that they were actually trained on. Engagement of the district chiefs, because we have community leaders. In the Gambia, we have community leaders that are very important. So we go to the different districts, because we have districts, we have divisions. So the divisions are headed by the commissioners. The districts are actually headed by the chiefs. So we go into the districts, which are small communities, to actually communicate with the community leaders there. And some of these district chiefs are very important because they are very powerful. And whatever they say, most of the time, the community actually make sure those things are actually done. So this is sensitization program with the district chiefs. We also engage the religious leaders, both the Christians and the Muslims, for them to actually give programs and activities on television. So on television, and also they were also engaged, part of the community outreach programs and activities that we were doing. So these are religious groups that are actually in radio programs, giving radio programs to the community and to the Gambia. Here also we used the First Lady of the Gambia, who is actually here. And here is also the Minister of Health. Here she was actually trying to sensitize people on television. So these things are also very important because you use prominent people to actually go into the community to discuss some of these challenges and educate the people as much as possible. And also, we also engage our president, who on television also, wherein he was also vaccinated, and also members of the parliament, the ministers, and etc. All those people were also television. We actually gave them filmed. They were actually filmed, and also this was transmitted on national television. So these things are actually very important. So these are some of the interventions that we actually did. And also we collaborated because, as we said, it's difficult because in this area of globalization, we have to collaborate with other countries. And Senegal, who is our sister country, we also collaborated with them. So we had study store wherein our team, the risk management and the treatment management, also went to Senegal and to get best practices from Senegal, and also to exchange ideas. And equally, the Senegalese people also came to the Gambia, where they spent almost about a month here we also exchange ideas and as much as possible did some demonstration and all these things for the interest of both Senegal and Gambia, and also for the interest of the whole of West Africa. Now, the conclusion, the issue about fear, worry on COVID-19 and vaccine hesitancy must be handled when dealing with the disease in the Gambia. So as you can see, these are major challenges that with the interventions, we are hoping that most of these interventions would help us to bring people to make sure that the vaccination is actually done. We have more people being vaccinated, because without vaccination, it is actually going to be very difficult to get what we want. And this can only be achieved by engaging cultural people, traditional leaders, religious leaders, and key influencers, and also district chiefs and women leaders, women and youth leaders. These things are very important, because all this engaging them would help us to get more people to be willing to actually come in and to get vaccinated, and the fear and the worry about COVID-19 also, by making sure that all the preventive measures are actually also adhered to. There is also need for collaborative work in social sciences between different countries, because as I said, Senegal and Gambia, they are just like brothers and sisters. Now there needs to be collaboration, because from Senegal, you come to Gambia. From Gambia, you also go to Senegal. And we are the same people, the same ethnic groups. Religion is the same. And also culturally, we are also interrelated. So there's a lot that we can learn from each other. And I think this can also be expanded to all the other countries, just like Ghana and Nigeria also, and for the benefit of this COVID response. So thank you very much. So I think this is what we have. Maybe we just allow any questions. Thank you.
Merci beaucoup, Dr. Bitey, pour avoir respecté le temps. Je vais peut-être passer la parole à Blessing. Have you any comment or anything to do to say? Blessing? Blessing? Tu m'entends? Blessing?
Yes, please, I am here.
Have you any comment or anything to? Yes,
yes, please. The speaker highlighted the fact that Gambia and Senegal being close to each other, there was no way of containing the disease in Gambia without also including Senegal in their containment measures. And so it's very important to note that as the world is a global village, we need the influence of other countries to help in each country's disease containment measures. And also he mentioned the fact that dealing with COVID is not just a science issue. We also have to bring in the social sciences part of it, talk about the religious aspects, what the people's beliefs, their the culture, and every other part of it, to make sure that any containment measure is multidisciplinary and so can be very effective. So thank you again for your presentation, Doctor. And I believe everybody is learning a lot from this. Thank you very much.
Merci. Merci beaucoup. Thank you, Dr. Bitey, for your presentation. Maintenant, je pense que je vais passer la parole au professeur Akosoa. Professeur Akosoa, est-ce que vous avez un commentaire ou faire un résumé de la session? Professor Akosoa?
Thank you. Oh, wow. Can you hear me?
Summary or comment? Yes.
Okay, so thank you very much for those three really enlightening presentations. For me, what was interesting was to see the ways in which the first two presentations and the last three are actually interconnected. As the Gambian presenter pointed out, there's a real importance in linking the natural sciences with the social sciences to be able to get a fuller appreciation of what we are up against. And his data on vaccine hesitancy is a really powerful example of that, because the natural scientists can develop the vaccines, they can bring it in, but until the social scientists explain the power of religion, as he so clearly showed in his data, we are not going to actually get the populations to use the vaccines. And in his case, he shows us very clearly the levels of vaccine hesitancy across the sub-region, which is something that we sort of know, but he puts the statistics to it. And so while, as in the Nigerian case, Dr. Ngozi pointed out that we do not have the vaccines yet, we also need to be thinking as a sub-region about the fact that even when we do get the vaccines, we might not necessarily get it into the bodies of our citizens because of vaccine hesitancy, and what to do about that. I think the other thing that was really powerful for me was the Senegalese presentation, particularly the discussions about the pre-existing precarity levels prior to the tsunami of COVID. And again, that's something that I think across the region we can appreciate. And so giving us insights into the ways in which the pandemic then intensified pre-existing conditions. It's also a message that I think we need to keep in mind. I found the statistics on the ways in which hunger had increased threefold, very powerful. And I think it links up with the Ghanaian case where Dr. Sanuede was reporting on the work that I had done and pointed to the fact that our pre-existing infrastructural challenges made it difficult for whatever the government intended to do for us to work fully. Few of our households are connected to electricity and water supplies, So if you give us free water, but the water doesn't actually flow in our taps, then we don't have the water in the first place. So I think what's been great is to show the ways in which, as a sub-region, we are quite similar in our challenges and in how we need to respond to this pandemic. And I hope that going forward, we can consolidate our perspectives and share across our countries in spite of our language divide and build a more resilient West Africa going forward. Thank you.
Merci beaucoup, Dr. Akosa. Je vais appeler le Dr. Aboubakar Diagne de la Gambie. Dr. Aboubakar Diagne.
Thank you very much.
Your comment?
Yes, thank you very much. It's a pleasure being here. It's just the fact that COVID has come to, in a way, expose our weaknesses. I think almost all the speakers have shown that, obviously all the studies have shown that all the things that were obvious to the eye that we couldn't see because of they've been perpetuating in our society for all these years, COVID has come to expose them. And the mere fact that it has come to expose them wasn't enough. It has given us the reasons to understand that probably there are things that we should take very important that we aren't doing. We should now make sure we use this opportunity to make them work. Only to build hospitals and to buy medications will not fix the problems that we have until we are able to put into our people an understanding of our health system and the health needs, and then putting into perspective our culture and difference in our attitude and behavior, and putting all this into perspective, making sure that every other person who is involved in the care of patients, including both the clinical scientists, the research scientists, and then the social sciences, will have to be part of this process. In Gambia, what we found to be very interesting is that the more we involve people, the more we involve the community and community leaders, the more we get reception for everything that we're doing, including the clinical care, including quarantine, including mobilizing even funds for COVID activities and then vaccination. So I think this is an important learning point for all countries. I mean, but more especially for West Africa, where we have been lagging behind in integration of all this group of experts who could do a lot of great job to the need for the people, the population at this material moment. I thank you very much for all your presentations and the people that have made this possible. I thank our sponsors for this presentations, and I thank everybody for taking time to do this. And I hope we can do more of this and collaborate more for the good of our countries. Thank you very much.
Merci, Dr. Brian. Merci, Dr. Diagne. Thank you, thank you. Merci beaucoup en tout cas pour la Gambie, pour votre collaboration, votre apport est très intéressant et très important dans ce projet. Nous allons peut-être ouvrir les discussions maintenant. S'il y a des questions, des commentaires et des questions, surtout en direction du public, si vous avez même des modérateurs. Hein, d'abord le public, si vous avez des questions à poser, vous pouvez lever la main et poser la question. Donc les discussions sont ouvertes. Des questions? Professeur Koumba Touré Kane.
Oui, bonjour professeur, merci beaucoup.
Allez-y, allez-y.
Merci de m'avoir donné la parole. Nous remercions l'Académie pour l'organisation de ces webinaires de renforcement des capacités. Nous apprenons beaucoup de choses et la COVID-19 également est venue, cette pandémie, nous apprendre beaucoup de choses. Non seulement elle a mis à nu nos faiblesses, mais elle a surtout montré la nécessité de pluridisciplinarité pour la prise en charge et la place des sciences sociales dans cette prise en charge. Et elle a aussi montré l'ingéniosité des populations, particulièrement le troisième âge. Et je voulais demander à professeur Nia, ce qu'on a vu dans la COVID-19, c'est que le troisième âge était isolé. Et quand on a vu l'avènement de la vaccination, le troisième âge s'est constitué comme des ambassadeurs. Ils ont montré non seulement leur résilience, mais ils étaient les premiers à aller se faire vacciner. Donc, je voulais vraiment que dans les policy briefs, qu'on puisse mettre en exergue la contribution de ce troisième âge dans la réponse contre la COVID-19. Et si professeur Nia peut revenir sur la contribution du troisième âge au Sénégal. Merci beaucoup.
Merci, professeur Koumba Touré. S'il y a une autre question, on va rassembler les questions. Pas d'autres questions? Donc, nous allons donner donc pour l'instant la parole au professeur Nia. Professeur Nia?
Oui.
Vous pouvez répondre à la question ou la contribution du professeur Koumba Touré. Allez-y,
Oui,
vous avez la parole.
Oui, j'avoue que je suis entièrement d'accord sur sa remarque. Effectivement, le troisième âge a joué un rôle fondamental à tous les niveaux de la réponse. Parce que déjà, dès les premiers cas, dans les interventions d'engagement communautaire, avant même qu'on ne parle du vaccin et de sa disponibilité, le troisième âge s'est investi pour crédibiliser un discours. D'abord, au niveau de la recherche, c'est les personnes âgées qui nous ont fourni l'appareillage conceptuel. Et comment il faut conceptualiser, il faut penser les challenges et comment est-ce qu'il faut mettre les concepts apparemment contradictoires, comment est-ce qu'il faut les mettre ensemble. Parce que si on oppose la logique binaire de la science classique a tendance à opposer les choses, c'est plus ou moins 1 ou 2, 0, 1, etc. Alors, ce qui fait qu'on a tendance spontanément à opposer le vrai du faux ou bien telle mesure par rapport à telle autre. Alors que quand vous discutez avec les dépositaires de cette culture, ils vous mettent ces deux éléments ensemble. Par exemple, il n'y a pas d'opposition entre le fait de croire que les prières soignent et la vaccination soigne aussi. Donc, par exemple, c'est-à-dire que si les gens disent qu'ils adhèrent d'abord à la prière, parce qu'il n'y a rien au-dessus de la prière, mais ça ne veut pas dire aussi qu'il faudra faire des mesures de protection ou de prévention qui vont aller dans le sens de la prière. Donc, dès le départ, vous avez ces éléments comme moytu ak dogu, wala ñaan ak fagaru, ainsi de suite. C'est-à-dire comment est-ce qu'on peut mettre ensemble des concepts qui sont apparemment contradictoires. Je crois qu'à ce niveau-là, le troisième âge a joué un rôle extrêmement important. Quand il a fallu engager, aller dans certains quartiers au niveau de la banlieue de Dakar, engager des volontaires dans certaines zones, aller dans les espaces de socialité comme les mosquées et autres, le troisième âge est sorti. Vous avez eu même des mamgokh, c'est-à-dire des grands-pères des grands-pères du coin, de la communauté ou du quartier qui ont appuyé les jeunes. C'est une manière de valider ce qui vient des jeunes et une manière de les accompagner. C'est aussi dans ce sens-là que tout ce qui tourne autour de comment recevoir un volontaire chez lui, comment discuter avec lui, ce concept de taranga que les personnes les plus âgées de la famille vont mettre en avant, va décrédibiliser le discours et permettre aux volontaires de faire le travail. Donc, je crois qu'il y a tous ces éléments-là. Ce qui fait que l'acceptation du vaccin n'est que la continuation de ce processus. Maintenant, quand malgré tout cela, il y a des résistances. Malgré tout ça, il y a des hésitations. Alors, surtout de la part des personnes qui accompagnent les vieilles personnes, paradoxalement. Alors, comment gérer cela? Là aussi, les voix des vieilles personnes peuvent jouer un rôle extrêmement important à ce niveau. Et aller plus loin, comment ces voix des vieilles personnes peuvent amplifier cette demande sociale, cette question autour du droit au vaccin et faire de sorte qu'il y ait une résonance internationale autour des voix des communautés africaines qui demandent à être vaccinées. Je crois qu'à ce niveau-là aussi, il y a des choses intéressantes à faire. Maintenant, par rapport si les vieilles personnes ont été en première ligne par rapport à ces questions-là, c'est elles aussi qui souffrent le plus par rapport à l'accès au traitement. Vous allez voir qu'elles vont rester longtemps avant d'accepter d'aller à l'hôpital. Et dans un contexte de pandémie où vous avez les gens qui meurent parce qu'ils ont tardé à venir dans les structures de santé et de prise en charge, ça pose problème. Là, c'est d'où l'intérêt de voir maintenant les questions philosophiques, les questions ontologiques, les questions religieuses qui sont autour du fait que les gens ont encore peur, entre guillemets, d'aller dans les structures de santé parce qu'il n'y a pas assez de confidentialité, assez de suture, ou bien ils pensent que mourir à la maison, c'est plus socialement et philosophiquement acceptable que mourir dans les structures de santé, que s'ils vont dans les structures de santé. Toutes ces questions-là aussi doivent être discutées et je pense que la vie des vieilles personnes peut jouer un rôle important et surtout, ils peuvent nous permettre d'avoir des concepts qu'il faut reconceptualiser pour articuler un discours qui correspond aux difficultés que nous avons maintenant. En tout cas, merci beaucoup de votre commentaire que j'ai fait mien. Merci. Allô?
Merci, professeur Agnan. Merci, professeur Touré-Kane. Le professeur Galaye Sall, vous voulez prendre la parole? Professeur Galaye Sall.
Non, monsieur le Président, je n'ai pas demandé à prendre la parole.
Donc, je vais pas... Merci beaucoup, professeur Galaye. Maintenant, je vais passer la parole au professeur Abdou Salam Fall à son équipe qui va peut-être dire un mot. Professeur Abdou Salam Fall.
Merci beaucoup. En fait, c'est ma collègue qui voulait placer un mot, celle qui a conduit l'enquête sur l'impact sur la famille à propos du troisième âge. Merci, docteur.
Elle peut, il n'y a pas de souci. Vous avez la parole, docteur Fall.
Merci beaucoup, professeur. Je me réjouis juste de
cette question sur la place et le rôle des personnes plus âgées. Parce que dans l'enquête que nous avions faite sur l'impact de la pandémie sur les structures familiales, on avait remarqué qu'en dépit des mesures barrières où on nous interdisait presque d'être en contact avec les personnes âgées pour ne pas les contaminer, ce qui ressortait des résultats de l'enquête, c'est que dans la période de semi-confinement, on avait observé que les répondants, trois quarts des répondants nous disaient que les discussions entre générations étaient beaucoup plus ouvertes, beaucoup plus fréquentes, et qu'il y avait eu un développement même d'activités communes, de circulation de l'information, de conseils, un ensemble d'indications qui provenaient de ce groupe-là envers d'autres groupes, notamment le groupe des descendants ou des membres du ménage qui étaient beaucoup plus jeunes. Donc, je pense que les enquêtes quand même confirment que ces personnes ont eu un rôle à jouer dans la diffusion des messages et dans leur capacité de covéance par rapport aux autres membres du ménage.
Merci beaucoup.
Merci beaucoup. Merci, professeur Fall. Je pense que cela conforte un peu l'idée du professeur Chernian qui veut renvoyer tout à la communauté. Je pense qu'il a raison. Et je pense que la communauté a un rôle extrêmement important à jouer dans cette COVID-19. Est-ce qu'il y a d'autres questions dans le public? S'il y a d'autres questions? Des questions, s'il vous plaît, ou des commentaires, des contributions? Professeur Salif Sow, est-ce que vous avez un dernier mot? Prof Salif? Professeur Salif, vous êtes encore là? Pas de questions. Je pense que nous arrivons au terme de notre conférence. Juste pour dire que nous avons en tout cas écouté aujourd'hui 5 conférenciers qui nous ont gratifié en tout cas de très belles prestations et nous ont passé en revue tous les aspects sociaux communautaires dans la lutte contre la COVID-19. Je pense que chacun d'eux a pu mettre en place, faire une analyse situationnelle dans son pays, au Nigeria, au Ghana, en Gambie et au Sénégal. Donc les situations ont été précisées, les facteurs aussi ont été précisés et des propositions et des solutions ont été proposées. Je pense qu'au terme de cela, nous allons, avant d'arriver à l'avant-dernier point, passer la parole maintenant au docteur Patricia Keuf, qui est membre de l'Académie des États-Unis, qui est à l'origine de ce projet avec M. Mbassou. Donc, le docteur Patricia Keuf, je vais lire en anglais sa biographie, is a senior program officer for the board on global health within the division of health and medicine, where she directs the Global Forum on Innovation in Health Professional Education, a position she had since 2012. Patricia is also leading the FDA-funded study looking at mutual recognition agreements in the regulation of medicines and a special COVID-related project with selected academies in Africa. Patricia worked for 11 years on the African Science Academy Development Initiative, where she was the country liaison to the Uganda National Academy of Sciences. She has directed and co-directed multiple studies at the national academies, including clinical trials during the 2012 or 2012, I think, 2012 and 2015 Ebola outbreak, options for overseas placement of US health professionals. Patricia joined the Academy's staff to work on the report, Emerging Microbial Threats to Health in the 21st century, before coming to Washington, D.C. Patricia worked at St. Luke's Roosevelt Hospital Center in New York City in the field of in the nutrition and as a counselor, researcher, and lecturer on topics of adults and pediatric hygiene. She received a Master of Science in Nutrition and in MPH in Population Family Health from Columbia University, and performed her undergraduate studies at the University of Connecticut. Here is the biography of Patricia Kirft. Patricia, you have the floor to tell some words about this conference.
Wonderful. That was the most comprehensive introduction I think I've ever received. Thank you, and thank you to the organizers and Professor Ndao in particular for this opportunity to be able to provide just some brief remarks. I want to start with my appreciation to the sponsors, and that's RTSL, which is Resolve to Save Lives. They provide us with the financial support to be able to run these regional as well as national activities. And I also want to thank them for setting up the Partnership for Evidence-Based Response to COVID. That's PERC, P-E-R-C. It's through that partnership that data and compiled into reports and briefs that focus on non-vaccine related responses to controlling the spread of the coronavirus. Now, those reports can inform conversations. Now, as we're seeing today, those conversations can be facilitated by academies. It's a perfect role for the academies. This, to me, underscores the importance of partnerships. And I've been hearing this throughout the day, the importance of partnerships between academies, experts, and policymakers, partnerships among academies in the same region to address regional challenges, and partnerships around the world to address global challenges, what we're doing today, dealing with a pandemic. So I want to share just a very brief anecdote that recently I was asked to assist in doing scenario planning. And I don't know if you're familiar with scenario planning, but basically what you do is you create a fictitious world and you provide assumptions in that fictitious world. And then you bring a group together who can solve a problem in this fictitious world. And what I thought the outcome could be is creating a playbook. And that way, with a playbook, you know exactly what to do. You just check off the boxes. But what I was told is that you can't necessarily predict what the next crisis is going to be. And if you try to predict it, you'll very likely get it wrong. So instead, getting a playbook with boxes that you check off, what you need to do is create trusted, what you need to do is have the knowing who to call, sorry. What you need to do is you need to know who to call. You need to know what their phone numbers are. You need to know that when you call them, they will actually respond and pick up your phone call so that you can actually talk to them. And then you can gather the experts together to brainstorm and think about how best to address the crisis. It's not about creating a checklist of items to accomplish. It's about relationships. So knowing who to call and knowing the value of trusted evidence-based advice, to me, is the greatest asset of the academies and what the academies really has to offer. Now, in that regard, in closing, on June 8th, I'd like to invite all of you to join us for one final virtual event that will be highlighting the African academies. And we will be sending the invitation to all of the academies and can share it more broadly. And if I can, what I'll do is I will provide a link to the registration in the chat. So with those brief remarks, I want to hand it back to the moderator and thank you for your attention.
Yes, Patricia?
Yes.
Yes. Thank you very much. Thank you very much. Merci beaucoup. Merci beaucoup en tout cas pour votre intervention. Nous voudrons en tout cas vous remercier très sincèrement au nom du président de l'Académie des sciences du Sénégal, de son secteur perpétuel. Vous remercier au nom de tous les pays qui participent à ce projet, l'Académie des sciences du Nigeria, l'Académie des sciences du Ghana, la Gambie et tous les membres de l'Académie des sciences du Sénégal. Donc, vous remercier très sincèrement pour votre apport inestimable dans la conduite de ce projet qui dure déjà depuis le mois de décembre. Depuis le mois de décembre, vous travaillez sur le projet et vous n'avez cesse de nous encourager, de nous accompagner en tout cas sur tous les plans pour qu'on arrive à ce jour. Et je pense que nous avons, au cours de cette séance, entendu beaucoup de communications très intéressantes. Et je dois dire que les prochaines étapes vont être cruciales puisque nous avons mis en place une équipe, en tout cas d'experts, trois experts sociaux qui ont pris des notes, qui vont travailler sur toutes les communications, qui vont faire des recommandations et ensuite faire des policy briefs. Donc, ces policy briefs vont être distribués, en tout cas partagés entre les différentes académies, le Nigeria, la Gambie, le Sénégal, le Ghana. Ensuite, on va faire disons, des contributions vont être faites et tout va être ensuite partagé de façon définitive afin qu'un rapport puisse sortir de cette conférence, un rapport qui sera transmis d'une part à l'Académie des États-Unis qui est porteuse du projet et qui va être évidemment diligenté vers nos gouvernements pour des actions futures. Donc, je voudrais terminer donc en remerciant l'ensemble des académies qui ont participé à cette conférence, le Ghana, le Nigeria et la Gambie, et de nous excuser éventuellement sur des impairs qui ont dû avoir lieu, surtout au début de cette réunion. Et cela, c'est inhérent à toute technologie, hein, ça c'est difficile. Nous attendons toujours notre secteur perpétuel qui a toujours des difficultés sur le plan technologique. Je ne sais pas s'il est encore là. Professeur Sok, est-ce que vous êtes encore là pour dire un dernier mot?
Oui, je suis là. Je suis
mais c'est très bien. Je vous passe la parole alors. Je m'efface et je vous laisse la parole pour que vous puissiez conclure et de faire des remerciements de l'Académie. Merci, professeur Sok.
Merci beaucoup, monsieur le professeur président Mamadou Ndoye. Je voudrais d'abord vous remercier parce que vous avez cru à ce projet dès le départ. Et ce n'était pas évident, les délais étaient très courts, mais vous avez réussi véritablement avec tout l'engagement nécessaire à le mener à bien. J'allais dire en anglais, we did it, puisque nous avons réussi à organiser l'atelier national en rassemblant tous les acteurs et aujourd'hui l'atelier international. Et je voudrais au nom de notre académie et de son président, professeur Doudouba, remercier encore une fois toutes les académies qui nous ont fait confiance pour participer à ce projet. L'Académie des sciences du Nigeria, l'Académie des arts et des sciences du Ghana et nos partenaires de la Gambie, dont la contribution est vivement appréciée. Bien entendu, je voudrais aussi remercier tous les partenaires du Sénégal, de l'Académie et de l'université qui nous ont permis véritablement d'apporter des contributions scientifiques de haut niveau sur cette importante question de la place des sciences sociales et humaines dans la lutte contre la COVID-19. Nous avons eu droit à des présentations de haut niveau au cours de ces 2 sessions, avec des cas donc, sur l'état de lieu des connaissances en sciences sociales et humaines sur la COVID-19 au Nigeria, au Ghana, au Sénégal et en Gambie. Et je voudrais remercier tous les modérateurs et bien entendu les présentateurs qui nous ont permis de rassembler toutes ces connaissances et ces pratiques qui nous permettront d'élaborer un rapport digne de ce nom et répondre ainsi aux attentes de nos partenaires de l'USNAS, que je remercie à travers Mme Patricia Keuf, et l'organisation Resort to Save Life également qui a financé ce projet. Donc, encore une fois, merci à tous. Je pense que l'équipe d'experts mise en place terminera le travail attendu avec donc l'élaboration des recommandations, la préparation du rapport et l'assurance du suivi et évaluation de ce projet. Voilà ce que je souhaitais dire au nom du président Doulouba et de l'Académie nationale des sciences et techniques du Sénégal. Et je remercie tout le monde. Voilà. Merci, Président Ndoye. Vous pouvez ouvrir la séance. Je vous laisse cette prérogative.
Je pense qu'il n'y a plus rien à dire. Hein. Je pense que vous avez tout dit. Remerciement à, en tout cas, toute l'équipe de l'Académie des sciences, en particulier de mes collègues de la section des sciences de la santé, qui ont travaillé beaucoup dur aussi, qui sont là, le professeur Mbouk, le professeur Papsalif Sow, le professeur Galaïsal, le professeur Abdelrahman Dia, en total, et j'en passe, je vous passe. Ils ont beaucoup travaillé dans ce projet, je pense qu'il faut se le lieu de les remercier aussi. Et d'autres membres de l'Académie, comme la section des sciences humaines de l'Académie aussi, qui a beaucoup travaillé dans ce projet. Donc, je n'ai pas grand-chose à dire, professeur Mbouk, vous avez tout dit. Hein. Donc, je vous repasse la parole pour déclarer clos cet atelier. Merci, professeur Sam.
Merci. Donc, au nom du président de l'Académie nationale des sciences et techniques du Sénégal, je déclare clos cet atelier régional virtuel de sensibilisation, de partage de policiers briefs sur les interventions non pharmaceutiques sur le COVID-19 au Sénégal, au Ghana, en Gambie et au Nigeria. Merci. La séance est levée.
Merci.